highlight what we're going to do today, have you introduce yourselves. Hand it back to Tom to talk a little bit about the process that you will go through as a panel, and also the public input that we are going to gather from various different sources. The bulk of today is going to be a presentation by Dr. Miles Belgrave. Gentleman in the back. We may have some tap dancing to do as he comes up here and sets up the process and works with the technology. We'll take a look at next steps, and then we'll open it up for any public comment. Primarily today's meeting is an organization and a knowledge gathering, knowledge sharing focus. The second meeting that Tom will go into greater detail on will be almost exclusively focused on gathering public input. But we want to always have an opportunity for folks to make comment to the panel at any of these proceedings. Is there a worksheet in the back? Did that make it? Okay. There's a worksheet in the back for those folks here that are interested in providing public comment to work today. It's a handwritten piece, but it is basically the format that is going to be on the website. And we'll also have roughly about 15 minutes at the end if folks would like to make comment. Is there any interest at this point in time in making comment? I'm not holding you to it. I'm just trying to check as far as timing and whatever. So any interest at this point in time? Okay, thank you. I'll ask again. I'll ask again before the end. Yes, excuse me.
I noticed we're being taped. Is that something that is usual?
Are we formally taping these sessions? I do not know, to be honest with you.
We had not planned. We were not.
Okay.
Taping them.
Okay.
We're not.
I'm assuming.
The public has the right to record.
Yeah. Yeah.
Okay.
So this, we're not formally taping it, but again, it's the public's right. Again, this is an open meeting.
Thank you for clarifying.
Certainly, certainly. Any other just sort of process questions before we get going on this? Okay. Want to have you introduce yourselves, your name, a little bit of background. You want to know who you are. And then the primary question, and I had to write it out because it gets long. Shorthand, there's a couple of shorthands, but it's basically, we're going to be providing information to the commissioner on this issue. Walking over here, driving over here, coming to this meeting, you gotta be thinking in your head, you know, how do I make this decision? What's going on with this? What information do I need to help me make a decision? This helps you get into the meeting, in all honesty. Also, it helps us gather your thoughts, your ideas, and maybe we can go out and do some research and backgrounding on that. So the third question is, what is one key piece of information, and I'm going to hold you to one, or knowledge that would be useful to you as you start thinking about what to recommend on the question of whether to add intractable pain to the list of qualifying conditions. Basically looking for that, what do you want to know? I'm going to see, will this work? Yeah. You can still see that, right? Okay. I'm going to write down your response to that question. But again, I'd like to go around the group, get your, where's my slide? It's your name, a brief amount of background, and then your one key piece of information. Who wants to start? I'll call on you if you, all right, listen. Mary, and we'll go counterclockwise. Seems counterclockwise today. Go ahead.
My name is Mary Pat Noonan. I'm a board-certified clinical psychologist at Health Partners. I work fairly exclusively in the pain management department. My one question is there a fatal dose of medical cannabis that we need to worry about for suicide risk?
I'm gonna try and get down the gist of what you say. I can't usually, as you can tell, can't write as fast as you speak. If I don't get it down right, make me get it right, okay? Let's go to the next
I'm
person.
Dan Truax, I'm
Thank
a PA, I work at Center for Pain Management in Sartell, and been doing that for quite a few years now. And the information that would probably help me decide best of anything that I can come up with would be the results of some of the studies, because I know there's a lot of studies out there. And I don't know if they've looked at it specifically like the way we're thinking, but I know there are some studies out there.
Okay. Thank you. Go ahead. Dean.
Neil Walker, I'm pharmacy manager at Fairview Range in Giddings. I manage the Giddings Hospital Pharmacy Services and 3 clinics on the range. And 36 years I've been there, and about 25 of those working on our inpatient chemical dependency and outpatient chemical dependency, which has since been closed, but then working in chronic pain with the ICSI chronic pain team. I guess my decision is going to be based on getting more information about the actual components of the drugs that are going to be used, not a plant cannabis, but cannabidiol, THC, and the components, and how decisions are made by the pharmacists that are making up the different components of these cocktails that are going to be distributed. And I think a key piece of information is how that is shared back and forth with the physicians that are basically credentialing their indication for use.
Great. Thank you. Go ahead. Ananda.
Yeah, my name is Orlando Chari. I'm an MD at Courage Kenny Rehabilitation Institute, both at Abbott and at United Hospitals. My work is 100% pain management, and I've been in pain management for the past 13 years. The question that I would have would be related to pharmacy and is regarding the interaction of the cannabinoids with other medications that are frequently used in individuals who present with intractable pain.
Great. Thank you.
I'm Nancy Jaworski. I'm a doctor of practice and a pediatric clinical specialist in children's hospitals and clinics. I treat acute, chronic pain, palliative, and hospice medicine. So we have patients in the home, in the hospital, and in the outpatient clinic. I think for me, it gets back to specifically what we talked about and how we're going to define intractable pain. Because I think there's a pretty broad spectrum from the legal definition to it, to, as I think about how I practice in palliative care, there's a way that we define intractable symptoms specifically, and we have a fairly systematic approach to how we do that, and the sorts of treatments that would allow once we've kind of made that decision. So for me, that's the thing that sticks in my mind is how are we defining intractable pain and what does somebody have to do to get there?
Okay. Hang on a second. Go ahead. Thank you.
My name is Art Weinman. I'm a practicing family physician and also with Health Partners. And I've been with them 33 of the last 35 years. I'm also the head of the family medicine department and one of the assistant medical directors, so I supervise several of our primary care clinics. And for the last 10 years, I have been leading our effort to improve the care we give to patients with chronic pain, particularly in the area of using opioids. 2 months ago, I was asked to head up our approach to understanding and implementing the new medical cannabis law. So I'm really anxious to hear what you have to say. Just as an editorial comment, I got my start in pain medicine by spending 1 day a week for 6 months with Dr. Belgrade. I sort of feel like Luke plus Skywalker, getting a chance to work with Obi-Wan Kenobi.
May the force be with you.
Yeah. Please, I really hope so. My question isn't a question of fact, it's more one of a process of how we do this. I'm so used to in medical questions looking specifically at the evidence and then balancing the risks and benefits, but you also talked about the social and public risks and concerns that are here, which is not something I'm used to working in. And my question is, how do I balance those together? And how do we as a group balance that? Because the evidence may lead us one way, whereas the overall discussion could potentially head us down a different path, which was interesting, a little bit scary.
Good. Come back over here.
All right, I wasn't sure if they caught
I'm Erin Krebs. I'm an associate professor of medicine and a primary care physician. I'm a primary care general internist. I spend the majority of my time actually though in research. So I'm a chronic pain, health services and outcomes researcher. And my research focus has been pain management, particularly in the primary care setting, and also with a focus on benefits and harms of opioid therapy for chronic pain. And I don't know how to say one thing. Really, what I want to see is a summary of the research that exists on the benefits and harms. And I'm interested primarily in the long-term benefits and harms since we're focused on intractable pain, which is a long-term condition.
Thank you. Go ahead.
My name is Amy Anderly Dotson. I'm a licensed alcohol and drug counselor and a licensed general social worker. So I've worked with a lot of people on the other end of this spectrum, not using it in the appropriate, comfortable ways and for the right reasons. One question that I had along with Nancy is how do we define the intractable pain, especially legal versus medical? But the other big question is diversion. With intractable, because the numbers increase so much more with adding intractable pain, how does that diversion add into it?
Great. Can we get every chance? Go ahead.
When I left work this morning, one of my co-pharmacists said, my neighbor's using medical marijuana. I said, well, it's not available until July. And I said, well, she gets it from her neighbor who gets all they want from Colorado.
Let me open this up, and it's slightly off the script here. We've listed 3, 6, 7, 8 pieces of knowledge. Is there a 9th or 10th one to add that you're just burning to? Because a couple people said, well, only one, and I forced you to only one. A couple of people did a very nice job of stating their one and adding a couple more with it. But is there anything that we're missing, is basically the question.
Do I get to add one?
Certainly.
I'd like to know what other states have done. Where else is it included as part of is intractable pain a reason for using medical cannabis? And what is their success or failure?
The first part of that we have in our folders as for the meeting today, and it's available on the back table.
Actually, if we're going to take beyond the state, it would be nice to know how the fact that it's still illegal under federal law is going to affect the decision we make and the recommendations we make. Since it is probably a somewhat different patient population when it comes to this, this would be very common within our commission.
Anything else? Okay.
I'll have one,
yes.
which is, and this is more of like another question to you guys, but what are additional voices or stakeholders that you would like to hear from during the process? I was just confirming with Michelle, we don't necessarily have specific people, I think, other than maybe today, that we're gonna put in front of the group, and so, and you don't have to say even right now, but as the process goes along, who are the voices that you'd like to hear from? Who should we provide to you as resources?
Okay.
Yes. The Minnesota Hospital Association has been working with all the major hospital groups. I think they're ready to come out with basically recommendations, and that's been a real struggle with. There's no other hospital in the country that will allow it to be used because of its status as a C1 substance, and CMS has said you'll lose your CMS accreditation if you allow it to be used. So that's been a fair view, and other hospitals have kind of backed off. So it's legally being looked at. The Minnesota Hospital Association has been looking at that. Maybe ICSI is wrapping up their statement more, looking at, and several of us here have been on that ICSI group, looking at ambulatory care and guidance for practitioners and those that would be not prescribing but certifying a patient to use it. So I think the ICSI statement is ready to be released. And then the Minnesota Medical Association has a very nice, comprehensive, about 8-page summary statement that answers a lot of these questions really amazing. So, and that is already published and out there. So.
Okay. With that, I'll hand it back over to Tom to take us through.
I just want to comment.
Okay.
We have some really good expertise around the table from a
variety of perspectives. So thank you again. And as I listen to where you come from, your clinical practice, your research practice, the perspective, the great question that you asked, I think it's going to be a great conversation. So I think we've got a rich team here to do the work that needs to be done. Good.
So next, we're going to talk a bit about the process over the next several months. There's something in the folders, and there's also copies in the back table, something called Intractable Pain Public Input and Advisory Panel Strategy. So the top of this document, the first page, is opportunities for public input. Just a little more detail on those. We're in the final stages of getting ready a link on our Office of Medical Cannabis website that will bring interested persons to the page that looks like the page on the table in the back, for them to write in their own comments. It can be anything that they want, telling their own story, what their hopes are. It's also an opportunity for organizations if they want to. There's information there about how information that would identify a person will be removed before this is sent on to the Minnesota Department of Health. And this will be done by MAD, the Management Analysis and Development folks. But if the organizations want to, they can have their name appended if they want to have an official statement from an organization. So that's one option, one opportunity for public input is written input that will be routed through a link on our website, actually administered by this other state agency, and then the information brought over to us, and we'll eventually make that, not personally identifying, make that available. Want to try to make things as transparent as possible. The second opportunity is testimony at public meetings organized throughout the state. We plan on organizing some meetings, various places outside the Twin Cities and places within the Twin Cities, to both describe what the program is and then to open it up for public comment. And Lisa will be along on these two. She's an expert at this, she's experienced with this, capturing the essence of the public testimony. Again, that's something that we'll put on our website so others can see what others are saying. Third is at the next meeting of this panel, which is not yet scheduled, but will be sometime in September, early September, I hope. We will do a couple of things. One is to hear from Dr. Gupta, who's a researcher at the University of Minnesota in intractable pain. And she has a really important clinical trial going on right now for sickle cell disease pain, and knows a lot about the biomedical and animal science and the clinical study information about the evidence in intractable that pain is that cannabis can have an impact in pain. So she's not a physician, she's a researcher PhD, but really been around the block on cannabis for medical purposes. She'll have a good presentation, I'm sure. And then we'll have ample time at that meeting for public testimony. We'll try to publicize it so that people who want to can come if they want to not do written comments but appear in person. The advisory panel itself then, going down towards the bottom of the page, on the next side, we'll skip over to, I guess it's sort of the meeting section I've talked through. We're anticipating that the third meeting, which will be either in late October or November, we're trying to push it up a little bit because the legislature has forced the commissioner to come up with a decision by the end of the year. So maybe in October, late September, October, a third meeting, which will be the time really to start seriously deliberating and trying to figure out what approach to take. The goal with this panel is to, the necessary outcome is to come up with a recommendation. We hope it to be a consensus recommendation, but it might not be. There might be a real split of opinions. And the way we're approaching it is that's okay. We'll just accurately represent the opinions of the group when it comes to recommendations. So we'll work towards consensus, but if that's not possible, then we'll have a split and try to accurately represent the differing opinions on recommendation. If need be, we'll meet more than the third meeting. We're hoping to have a half day, and we'll give a lot of thought to structuring it. There is, if need be, we could put in time to hear from someone else if it emerges that would be a good idea. And just in general, we're kind of building this as we go. So if you have ideas about how you think it would be good to hear from someone or to do something structured into our process together, let me know. We'll try to make it happen. Anticipate we'll try to start setting up these meetings relatively soon because it's hard to get the right sort of space. We might go ahead and schedule 4 because it's easier to schedule something and then not use it if we don't need to. Something that is going to be valuable, I'm very excited about, is that we're going to be commissioning a formal, rigorous literature review and grading of the evidence for medical cannabis in non-cancer chronic pain. Now, if you've been looking at this literature at all, you already know that there have been 3 of these done so far, 2 by the same research group. I've read them, some of you have read them, I'm sure. There are some problems, I think, with them. And we've decided that it's worth the effort and the cost to go ahead and commission this to be done by an independent body that really is expert at doing these sorts of reviews and is not an advocate one way or another on the topics that they take on. And we're not quite ready to announce who will be doing this, but it will most certainly be a well-respected institution from the state, from Minnesota, with great experience and expertise doing just these sorts of reviews. And I think it will be a very valuable contribution both to the panel, to the general public, and really to the nation, because I think that this will be a definitive, by sort of highly structured, by standards such as are used by the agency or recommended by the Agency for Healthcare Research and Quality, the federal government, to really do the best job you can. And it's needed in this area because it's so broad. This non-cancer chronic pain is so broad. So that, unfortunately, will not be done until the end of September. If you would like to have the citations for those other 3 articles, although they have some problems, they do a pretty good job of giving the articles if you should want to try to find them on your own. Let me know if you think that'd be a good idea. We can certainly send out the citations or the PDFs of the articles. Oh, one more document that actually came up in the comments is the What's Happening in Other States document that I put together. I take all the blame for typos or inaccuracies, but what I did is I went to each state's website. So it's limited to what the states put on their websites, but they pretty much all have their statute and the rules and a statement of what the qualifying conditions are. As you might be aware, every state that has a medical cannabis program that's at all robust has their list of qualifying conditions. But how they approach it is really different, even just structurally, it's really different among them. And certainly they vary in how they approach chronic, severe pain. And so what I've done is tried to give a useful context to how severe or chronic pain fits into the conditions. And it ends up being a little bit lengthy because you almost have to do that so you understand their approach. Some take the approach of they just say chronic pain. Others say, well, you have to have a diagnosis, one of these diagnoses, and one of these symptoms. And so you might, chronic pain might be one of those symptoms, but then you also have to have a specific diagnosis. 2 do not, almost all do have some sort of address of chronic pain, but it might only be for certain conditions. Illinois, for example, which is a relatively new program, instead of taking on chronic pain or intractable pain, what they're doing is they're going a la carte, I guess you would say. So they're saying it's like diabetic neuropathy and this potential cause for chronic pain or intractable pain. And so they already, their list is already like up to 60 or 70 or something like that. They just had a meeting where they covered 30 different conditions in an hour meeting. So I'm not sure we're going to do anything like that, but I mean, in terms of a long meeting, for other conditions later. But really, I think that this was helpful to me because it just gave a sense of the wide diversity of how the different states are approaching it. So if you have questions about this, let me know. But really, it's taken all from the website. Oh, the third column is when there is information on the website, is the proportion of patients who ended up being certified because of that chronic pain or severe pain condition. And it's usually pretty high, except for New Mexico, where it was quite a bit lower. And their number one cause for enrollment was post-traumatic stress syndrome, PTSD. So I think that is all that I have to say on this topic. Any questions or comments before I go on to introduce Dr. Belgrade in his presentation? And do we need to notify the staff for anything, or do we ourselves try to get the projection ready? Now's the time to switch it over and get ready. Yeah.
So there have been estimates of the current approved conditions, there might be 5,000 or so patients, and I've heard figures thrown out to maybe 100,000 patients if intractable pain is approved. Is that accurate? Is that just a guess based on some of these percentages in other states?
Yeah, that's a hard one. I'll take a crack at this one. The 5,000 guess is just the best estimate, and I sort of wondered myself. So apparently it was modeled after Arizona, and so I looked into Arizona's figures. And bottom line, after I scratched my noodle a little bit, I think it's a decent estimate. It's very imprecise. So then I looked at the proportion of their patients who qualified because of intractable pain. Right? We don't have it, they do. And my guess was not a multiplier of 20. It's more like maybe 5 to 8, something like that. Again, just a guess, but still a relatively large magnitude. So if the $5,000 count is somewhere near the mark, that's the number of enrollees after the end of the first year, then my guess, just a guess, based on really the Arizona experience, would be something like maybe 25 to, it's like 5 to 8, 8 to 40, 25 to 40 additional. So very substantial number.
You know, there's some, and I'm sure we're all familiar with this, some unfortunate wording in the 9 qualifying conditions in the law as it applies to the severe persistent muscle spasms, including those characteristic of multiple sclerosis and CMOS. At our clinic, and I think this reflects what you did in your survey back in February, was 51% of the patients who responded said they might visit said muscle spasms, and I'm fairly sure most of those would not have had some sort of CNS lesion. And I know with health partners, when we're getting questions at primary care, it's patients who have severe muscle spasms unrelated to central nervous system lesion, which have pain. So I suspect we'll see the same sort of thing in the other areas as we move forward.
Thank you. Are we ready to go with the presentation? So it's my pleasure to welcome as our speaker today Dr. Miles Belgrade, who is a neurologist and pain specialist in the Comprehensive Pain Center at the Minneapolis VA Healthcare System. He also practices at the Minnesota Head and Neck Pain Clinic and is associate professor in the Department of Physical Medicine and Rehabilitation and adjunct professor in the Department of Neurology at the University of Minnesota. For the last 25 years, he has been the medical director of pain services at hospitals in the Twin Cities metro area and teaches pain management to students, residents, and fellows. So I'm so appreciative, Dr. Belgrade, that you came in to join us.
Well, thanks for inviting me.
Today. We're going to have about an hour in the presentation, and I really think the opportunity for question and answers might be extremely valuable for this group.
Right, and if there's something along the way that needs us to go off script, I'm fine with that. I think that might even be better. So I just want to start by saying what I'm not going to talk about. I'm not going to talk about marijuana or cannabis, and that's everybody's understanding, right? I'm going to talk about pain management. So let's keep that's sort of the ground rules. I'm hardly going to talk about marijuana or cannabis. But I do want to present to you what's sort of the state of things with respect to pain management nowadays. And I'm going to do that by starting out with 2 patient cases that I won't talk about, we'll just present them, let you stew about those, think about them, and then I'm going to present one other case and look at how we assess that case, how we come up with a treatment plan, and then we'll come back to those 2 cases and you can think about, are these people that you would recommend medical marijuana to? Are they people that you wouldn't, both of them, or none of them? And you can just be thinking about that, food for thought. So let's see, spacebar. Here is a tale of 2 patients, written not by Charles Dickens. The first one is London, and the second patient is Paris. Let's look at London's story. She's 47 years old. She has chronic back and left leg pain since a vehicle accident about a dozen years ago. And she works part-time in retail sales. She can't stay on her feet more than about 6 hours per day. She's only working 30 hours a week. She exercises at the Y a couple of days a week. She's married, she has children, she has grandchildren. Her doctor gives her 30 hydrocodone per month for pain flares, and she usually has some left over. She doesn't like using them. She takes citalopram for depression, and now she's asking her physician, what can she do to improve her endurance and her quality of life, and she grieves that she used to run marathons before her back was injured. So that's London. Let's look at Paris's story. Paris is also a 47-year-old woman with chronic back and left leg pain since a motor vehicle accident 12 years ago, just like London. She works as a PCA for her aunt, and she works 12 hours a week, and she does something like housework for her aunt who has fibromyalgia. She doesn't have an exercise regimen. She has PTSD from sexual assault as a teen. She's had early childhood trauma. She's had a difficult growing up time. She sees a psychiatrist who prescribes alprazolam, a milligram 3 times a day for anxiety, PTSD, and so on. She's a single mother of a daughter who's currently in a treatment program for polysubstance abuse. Paris takes 8 hydrocodone tabs per day. Her prescription runs out too soon. Her aunt is willing to supplement some of her supply so that she can get to the end of the month and get her next prescription. Other pain problems that she has, there are some. She has chronic headache, irritable bowel syndrome, TMJ disorder. Now she's asking the doctor for something stronger for her pain, and she's also wanting something to help her sleep. So these are 2 patients with the same accident, you might say. Let's take a look at some of their findings. London, on exam, no pain behavior. She's not groaning, grimacing, limping, none of that. She has pain when she tries to extend her back. She's got tenderness at the left buttock muscles, and then pain radiates down the leg when you press on it. Her strength is normal, and her lumbar MRI shows a disc bulging and mild stenosis, left lower lumbar. Paris's exam, she's tearful, she has labored movements, she favors her left leg, and she has very limited back motion in any direction. She's tender, not just at the buttock muscles, but really pretty much everywhere, head to toe. Strength testing is limited because of give-way weakness in most of the muscle groups. And her lumbar MRI, well, they match. Shows a left L5S1 disc bulging and mild stenosis. So these are the 2 patients, tale of 2 patients. You can be thinking about them as we go along. And so what I want to try to cover today is a little bit about anatomy and physiology of pain, how it's transmitted, how it's modulated, how it turns chronic. And then how we assess pain. We're looking to look at physiologic pain types, because these will guide our treatment, what contributing factors there are to pain, what barriers prevent us from being successful in pain assessment or management, and what degree of disease burden are we facing. We might think of this as how intractable is the condition. And then we'll look at pain management. What medications do we use for the different pain types? I'm not going to be talking too much about interventional. We have other experts in the room who could do that. What physical rehab measures could be taken, what complementary therapies, behavioral strategies, and so on. And then we'll come back to our 2 patients. So I want to start, if this works. Let's see if it does. No, I don't need audio. Oh, good. It looks promising. I want to start by looking at pain transmission. How is pain transmitted from what looks like it's going to be a pinprick here to, oh, hang on a second. There we go. Okay, so this is a 30 seconds of me. Oh, it doesn't work. Too bad. Oh well. And I don't know what happened. It sounded like you were able to get the video working.
Just put the PowerPoint screen, you can play it something piano,
It's not actually a video, but. Okay, well, that probably means the other one won't be either.
Who's that?
I did bring mine, but I hate to make a federal case out of it. But, basically, we'll just say what it is. It would be much prettier, but basically, you have a stimulus that produces pain. And that has to make some peripheral nerve fibers, certain ones that carry the pain signal. These are called C fibers or A delta fibers. It carries the signal up and along the first sensory nerve. It goes into the spinal cord. It makes a connection with a second order neuron within the spinal cord. And then it sends a signal across to the other side and up to the brain. A little relay station in the thalamus, but then it projects to a couple of centers, actually quite a few centers in the brain. One is the somatosensory cortex out here, where we feel pain as a pain stimulus and not some other stimulus like touch or pressure, position sense. And we can rate its intensity. We can say it's 6 out of 10, 8 out of 10, or 1 out of 10. And we identify it as pain, and we can map where it's coming from, all once the projection gets up here. The other projections give us some other information. They give us the emotional component of pain, the affective component. And those projections carry the signal into the limbic system, which is our emotional processing area of the brain. And so we have these two pieces of pain. One is just the facts, that's out here, and the other one is the emotion that makes pain really an important clinical problem that creates desperation in people, and so this is unique to pain. You don't see this with just say vibration, for example, usually. So okay. And in the periphery, what makes those pain nerves fire? Well, there's three kinds of stimuli that make them fire. One is, well, the pinprick, which you might call a mechanical stimulus. Another type would be heat. If you heat the nerve up to a high enough temperature, it'll fire and you'll have pain. That temperature is something around 45 degrees centigrade. Certain chemicals can produce that firing of the nerve, and one of them is capsaicin. And actually, all of these things, heat, and the temperature and the chemicals, can make this nerve fire by activating this famous receptor here called the transient receptor potential vanilloid type 1, TRPV1 receptor. It activates in response to these elements, and then it depolarizes this pain nerve that takes the signal up to the spinal cord. It turns out that even mechanical stimulation through an intermediary protein called G protein will activate that same TRPV1 receptor. Anybody know what anandamide is? Ring a bell? It's a cannabinoid. So it also activates the pain sensing nerves. Now, okay, well, I told you I wasn't going to talk about that.
Well, is there anything you could say more about how you want some research on it?
On anandamide?
Yeah.
No, I don't. The only thing I know about it is that it's a cannabinoid. How does, and you notice capsaicin was up there as something that triggers this TRPV1 receptor and produces pain, and you know that capsaicin is an ingredient in hot peppers that makes them feel like they're you're burning. So why is capsaicin on the market as a pain treatment, you might ask? The answer is that if you apply capsaicin repeatedly, you will deactivate that TRPV1 receptor. And so it's the repeated application. And most people don't use capsaicin in the optimal way. They use it on an as-needed basis and as a sort of counter-irritant. And that's not really its best use. Its best use is to gradually, over about a month of repeated applications 3 times a day, deactivating the TRPV1 receptor. So next, let's go into the spinal cord and take a look at this nerve coming from the periphery, and it wants to activate the pain signal across the synapse to the second order neuron, the next neuron upstream, and it has to release some nasty chemicals there, neurotransmitters that are excitatory, and it needs the help of these yellow balls, which are calcium. And if calcium can get into that nerve, then this nerve, this pain-sensing nerve, can release its excitatory transmitters and produce pain upstream. If calcium doesn't get into the nerve is shut down and won't release these chemicals. So if we were drug researchers, we'd be looking for a drug that, here's this channel that calcium can get through, that reduces the activity of that channel, and there are a couple of drugs that do that. One of them is gabapentin, brand name Neurontin. The other one is pregabalin, brand name Lyrica, and that's how they work. They reduce the influx of calcium when there's inflamed or abnormal firing of the nerves, and it quiets it down more towards a normal level. Doesn't block it completely. And that's how those two drugs work now in the nervous, on the peripheral nerves. It also does the same thing in the central nervous system, and that's why those drugs are also used for epilepsy. It controls that irritable firing of nerves by reducing that calcium influx. I can skip that. And remember I said pain projects to 2 main areas of the brain. One is the limbic system, and the other is the somatosensory cortex. The somatosensory cortex giving just some neutral facts about pain, and the limbic system giving that affective, emotional component. Well, here's the first study. This was done about 15 or so years ago, 17 years ago, by Rainville, who looked at that using PET scanning, and he was able to show that volunteers who were willing to put their hand in a warm bath or a hot bath, he was able to show that what lights up in the brain on the PET scan are these 2 centers. The somatosensory cortex that tells your brain that you've got a pain stimulus in your hand that's in the hot water, and the limbic system, anterior cingulate cortex, that tells you it's unpleasant. It's 2 different things. If you had no limbic system, you would still say, this bath is hot, it's 8 out of 10, pain, my hand is burning, but you wouldn't be motivated to take your hand out. So the motivating factor is this limbic system. And what he did was he hypnotized these volunteers who did this experiment, and he trained them to reduce the unpleasantness of the experience. And then he looked at their scans, their PET scans, and what he's able to show, and I suppose we don't have a pointer, do we? I wonder if I could use is there a little, oh, yeah, there is. What he's able to show is that here's the somatosensory cortex. Well, under hypnosis, the amount of lighting up of this facts area of the pain is about the same. But if you notice, here's the anterior cingulate cortex, part of the limbic system, and with hypnosis, this is all reduced. So what hypnosis did is it reduced not the facts about the pain, it was still pain, it was still rated about the same, but how unpleasant it was rated. And these are 2 important components of pain.
Miles, with acupuncture, are there similar mechanisms?
Yes, right. And I have a couple slides on acupuncture too. Here's pain modulation. The body modulates pain in a number of ways. This was the earliest modulation scheme that was theorized by Patrick Wall and Ronald Melzak. Melzak's still alive. And this is called the gate theory of pain. And what it postulates is that there's a competitive inhibition between the large nerves that carry non-pain feelings, good, happy feelings, L for large, S for small. That small, thin nerves that have no myelination or insulation, they carry pain signals. And through this inhibitory neuron, you can either reduce pain input to the brain, or you can, if you inhibit the inhibition, you can increase, here we go down here, pain input to the brain. And what activates the inhibition is the large nerves that carry nice feelings, and what deactivates the inhibition are the small nerves that carry pain feelings. So you get the large fibers that have touch, pressure, rubbing sensation. They will activate an inhibition of pain. They compete with the pain signals, whereas the pain signals will promote the progression of pain up to the brain. This is the gate theory. It was the first theory that identified a modulating system in the brain. Here's the other main modulating system. It's called the descending inhibitory pathway. It comes from, well, here we are in the anterior cingulate. This is the limbic system. We've got a series of nerves that comes down to the brain stem, lower in the brain stem, lower in the brain stem. It's a series of 1, 2, sort of 3 relays here that block pain right at the spinal cord here, in the same place that the gate mechanism did, in the same place that this calcium blocking did from gabapentin. All of our blocking takes place way down here at the dorsal horn of the spinal cord. And it turns out, has to do with calcium. All these mechanisms end up blocking the input of calcium into the nerve so that there's less activity, less neurotransmitter release. And the thing I want to say about this is that each of these nerves uses a different nutrient, or transmitter you might say, to carry its nice blocking signals. We're so happy that we have these modulating systems. And for example, you can see dopamine is one of the neurotransmitters for this pathway coming down and blocking. Norepinephrine blocks it from the locus coeruleus down to the dorsal horn of the spinal cord, and serotonin from the rostral ventral medulla down to the dorsal horn of the spinal cord. And this is the basis for why these antidepressants, and actually even some of these dopamine-enhancing drugs, can block pain. Because they work through the system, they enhance our ability to use this downward blocking system. So we've talked about a couple of treatments for pain already. That gate theory, we use that gate theory all the time, just through rubbing, counter-irritation, stimulation. So what makes pain chronic? Different things. You can sensitize the nerves peripherally. You can sensitize them centrally with some elements called wind-up, by activating glial cells, by taking away the normal input of the nervous system. And you can actually reorganize the structure of your cortex to facilitate pain and make it more of a problem. And that reorganization is sometimes referred to as connectivity, which sounds like a good thing. We all want to be connected, there's social media and all that. But actually, connectivity is something that creates pathological pain amplification. Particularly, this has been shown in fibromyalgia cases. So, and this all takes place in the brain. So we're starting to see how complicated pain is and how it can be perpetuated and amplified at many different layers of the nervous system. And here's peripheral sensitization. If you have inflammation, you cut your finger and it gets inflamed or it gets infected, then all these nasty white cells start getting localized around the nerve. Here it is. And they start releasing these nasty chemicals, prostaglandins, tissue necrosis factor, prostaglandins, interleukins, histamine, all these things, various cytokines get released, and they're in a soup around here, and they sensitize this nerve so that it fires to even much less of a stimulus, even a non-painful stimulus. So that's called peripheral sensitization. And one good thing that that peripheral inflammation does is that it upregulates opioid receptors on the nerves. And it was at the University of Minnesota that it was discovered that our peripheral nerves have opiate receptors. We used to think it was only in the central nervous system. But Ken Hargreaves, a dental researcher, he identified in the setting of inflammation, you get opioid receptors on the peripheral nerves. And when there is no inflammation, those receptors kind of go away. And so we use that to create a topical gel for these cutaneous ulcers and other localized inflammation areas on the superficial tissues that are painful, like ulcers can be. We put morphine in this gel called Intractable gel, and we apply it to the wound, and it attaches to the now activated opiate receptors, and you get localized pain control using morphine. So now, how else is pain made chronic? The nervous system has a way of chronifying pain when it's injured. And when, I'll just orient you here. Here's the periphery, here's my hand out here. These are the nerves from my hand, the good nerves and the pain nerves, we say. The good nerves are big and fat, the pain nerves are thin. And across the synapse, now in the dorsal horn of the spinal cord, is a second order neuron that's trying to carry the signal up to the brain. And when nerves are injured, you get ectopic impulses firing, automatic firing, say in diabetes, for example. If you have an injured nerve, you can get what's called ephaptic transmission, so that pain signals can, in a damaged nerve, can be transferred from a non-pain nerve just by touching the skin, can short circuit across and activate, depolarize the pain nerves, and just pulling somebody's socks off might be painful in that situation. If you completely or almost completely eliminate the input, like let's say you just say, okay, my hand is hurting so bad, nothing's working, it's intractable pain, amputate it. I'm not even using my hand anymore. What then happens is the second order neurons get irritable. They don't like not having input. And so it's sort of like if you're in a room by yourself, pretty soon you start just talking to yourself. And you don't even know how to regulate it because there's nobody there to say, hey, you're talking too loud. So they start talking too loud and they get activated and you get this amplified response upstream. And as far as the brain knows, it's getting the same kind of signals it got before, and the hand is hurting. And even if the hand were cut off, it would still be hurting. So that's one explanation for phantom pain. And then if you have repeated stimulation, repeated insults into the same system, you get what's called wind-up or central sensitization. Normally we think of, gosh, if we're at a concert, our kids' concert, and they're playing terribly, and it's loud, and it's out of tune. Well, after a while, you know, we just learn how to tune it out. But don't we? No, my kids were great musicians. But in the case of the nervous system, it does the opposite. The pain system amplifies when you have repeated insults. Let's talk about this fellow. His name's Tom. That's not why the T is on his cheek, though. Tom came to Stanford Medical Center. He saw a neurologist there named Ramachandran. And he's a guy who had a left below the elbow amputation. I don't know the reason for it, but he had this amputation. And he was starting to get phantom limb pain. And the other thing that he noticed is that if he touched his cheek, he would feel the phantom hand that wasn't there. Oh, left side. If he touched his left cheek, he would feel his phantom hand. And not only that, if he put something cold on the cheek, the phantom hand would feel a cold stimulus. It was modality specific. If he dripped water on his cheek, it would feel like water dripping on his hand. And this fascinated the neurologist at Stanford, and he came up with a theory as to why that would happen. And he remembered from medical school this Penfield diagram that shows how the body is mapped onto the brain. And he says, well, gosh, it's true that, let's say, this area has been kind of taken off the grid because of the amputation. So what's going on here? It's so close to the face that it's possible that some of the nerve fibers from the face are taking over that site. And now if you stimulate the face, it's going to be felt in the hand. So he's hypothesizing that there's a reorganization of the somatosensory cortex to include a broader area. And that is one example of central nervous system plasticity or change, which we used to think was hardwired. If you look deeper at a different homunculus, different projection, this is now a cross-section through the thalamus. And you can see it's even a closer approximation to the face. Never mind this tail, because these studies were done in rats, but because Tom wouldn't agree to have this brainstem section. So, but if you look at this, you can see how it wouldn't take much growth of nerves to supply this hand area. And the other thing I have labeled here are some acupuncture points, like large intestine 4, this famous point here for pain where? Pain in the face. And this point, pericardium 6, which is right here, which is used for nausea, but it's also the point that governs the whole chest and upper abdomen. And this point here, stomach 36, probably the second most famous acupuncture point, just below the knee, and you can see it's really closely approximated to this section of the body, and this is the distal point in the knee that influences the whole abdomen, the lower abdomen especially. So it's interesting, we have now an acupuncture correlate. Now why would stimulating this point take away a headache? Turns out that in the nervous system, when you stimulate a part of the body, you get activation there, but you get inhibition in an area around there. And so that surround inhibition may be an explanation for why these important key points in acupuncture reduce or modify the experiences that are going on in these more central body regions. So what did they do with Tom? He had phantom pain. They had to do something about it. So they tried this experiment. They took a mirror and a box, and they had him put his good hand in the mirror, and the mirror was along here, and you could see the reflection, and it looked like his left hand, but a normal hand. And so they had him doing exercises with his good hand while looking in the mirror at his sort of mirror image left hand that wasn't really there. And over time, with enough movement, manipulating things, clapping, he was able to normalize the experience, and they hypothesized again that you get reorganization in a good way of the cortex so that you reduce the phantom pain sensation. And he had a good result. He had reduced phantom sensations, and I don't know what happened to the dripping, but at least the phantom pain was less. And so even the US Army has come out in favor of using this mirror, they call it mirror box therapy or mirror therapy, to change how the brain responds to some of these pain inputs. And so here's a serviceman who had an amputation, and he's using this mirror and then working with the remaining leg to reduce an altered sensation in the phantom leg. Now we're going to talk about something called the neural matrix, which actually nowadays it has a new name. It's connectedness. And this neural matrix was really invented by Ronald Melzack, about 25 years ago, 20 years ago maybe, because gosh, he invented the gate control theory of pain in 1965. He's getting older, and he had to come up with something else great. So he came up with this concept of a neural matrix where the hypothesis is that every time we have an experience, it's codified in the brain through interacting neurons, and they form little networks that way. And theoretically, any connected set of networks is going to be activated if you activate any part of that network because they're connected. So for example, he's trying to come up with a theory for phantom pain other than what I told you about. So if you're a baseball player and you're used to doing this 1,000 times a season, and then you have to have an amputation, then there are so many tight networks in the brain that if you were to have a movement like this, it would trigger some part of this that would then activate the whole thing, and you would experience the entire thing, the entire sensation, including the hand. It would all be there because these work in concert like cobwebs, all spider webs all connected together. If a fly hits this part of the web, the whole web is activated, and the spider knows it can go get the fly. So these neural matrices are an explanation in part on how people can have traumatic experiences early on in childhood, and then later in life they could have a traumatic experience, maybe not even that traumatic, maybe just a fender bender, as opposed to being slammed down in a bed or raped or something horrible. They just rear-ended. But that rear-end collision then ignites the entire tight network that was built up in childhood, and what do they experience? The whole experience. And so it's a good explanation for how PTSD might be operating, at least in part, through these neural networks, or nowadays we're calling it connectedness. So Vitaly Napido is at Harvard researcher who's also an acupuncturist. He decided to look at brain connectivity and fibromyalgia. And what he showed was that, you can't really tell from this, but they looked at certain default networks, some of these neural networks, and they showed that fibromyalgia patients have a heightened connectivity. You might say their brain is kind of socked in with connections. So much so that all kinds of experiences create the pain experience because they're all connected together. In particular, a part of the brain called the insula connects with some of the pain centers. And then, and the more connected you are in fibromyalgia, the more connectivity there is on these functional MRI scans, the higher your pain score is going to be to a stimulus. So the connectedness correlates with the degree of pain. And then he said, well, let's see if we can modify that connectedness. And so he did acupuncture on fibromyalgia patients. And he looked at their some pain scales, affective and sensory, and he showed that after acupuncture he could reduce the pain experience in fibromyalgia patients. He could increase their threshold. And the other thing he showed was that it was correlated with the amount of connectedness that was changed after acupuncture. So there was a reduced connectedness, and that correlated with how much pain relief a person got from acupuncture. Then how are we doing? Pretty good. Let's look at, I think this is the last sort of physiology of pain section that I have. Let's look at the glial cells. What are glial cells? These are cells that are located throughout the nervous system, and in particular in the central nervous system. And we always thought, I was taught in medical school, these are structurally supportive, they provide nutrients to the nervous system. It's sort of like a trellis for a growing plant if you want to shape in a certain way. But it turns out that the glial cells are key in perpetuating and amplifying pathological pain. And every model of pathological pain, whether it's inflammation or neuropathic pain, has shown that the glial cells are activated, overactivated. And these glial cells produce certain chemicals like cytokines. They activate neurons just like another neuron would, and they amplify pain signaling. And research now is looking at how do we inhibit these glial cells from being so overactive, because it turns out that the glial cells are responsible for the sick feeling that we get when we have an infection. They're responsible for all types of amplified pain, not normal pain, not just pinprick pain, but pathological pain. And they're responsible for opioid craving in the brain. And so if we could inhibit these glial cells, we would have a good treatment for pathological pain. And so a lot of research is being done to do that. And one of the, well, I don't know, there are glial cell inhibitors that look promising. And, oh, yeah, I am going to do, this is one last thing on physiology, but this has to do with pain that goes even beyond the individual who has the pain. And really, doing all this, I'm trying to show you how complex pain really is, how multifaceted it is. Because it goes beyond just the individual with the pain. It goes even to their environment and their social spheres. So this is a study that was done by Jeff Mogul at the University of Illinois. And he had a model for pain. He'd inject acetic acid into the peritoneum of rats. And what do? When they get that? It's painful, and they start writhing. Now there's a little delay, and then they start writhing. And the way all lab studies are done with rats is they always have cages of 4 rats. They always did, and maybe they always will. And they're all male, by the way, but they have these rats in cages of 4. And so he did the experiment. He put the acetic acid in, he put the rat back in the cage, then he took out the next rat, and by the way, they're marking how long it takes the rat to start writhing from the acetic acid. Inject acetic acid in the next rat, put it in the cage. It took a little less time to start writhing. Took out the 3rd rat, injected the acetic acid, put it back in. Took an even less time for that rat to start writhing. He's starting to wonder, okay, why is this? Why is it different for the different rats? Is there something that's socially mediated here? So if you look at it, the first rat, this is time to writhing latency, is here. The second rat here, 3rd rat here, 4th rat here. What's going on? It's the same stimulus, same amount of acetic acid. And this is, here it is in their home cage. These are CD1 mice, whatever that is. And you can see this descending graph. And he said, okay, I'm not going to put them back in the same cage. I'm going to put, once I inject them, I'm going to put them in a holding cage. Then what happened? There was no reduction in the time to writhing. So each one had about the same latency in the pain response. And then he wondered, okay, what is it? Is it that they're smelling this rat? Are they hearing it screaming in some tone that humans can't hear? Are they watching it? What is it? Well, the first thing he wanted to find out is, do you have to be familiar? Do they have to be familiar with their brother rats in the cage? And it turns out the answer is yes. Because if the rats were only in the cage for 7 days together, it didn't happen. That loss of time to writhing didn't happen. But as they got to the 2-week mark, then they had that changed latency. Shorter time to writhing. So why is that? Well, he took different genetically modified rats. Here's the control situation, where you might call this time to writhing, the response, let's say, is increased. If you take the smell ability out of the rat genetically, it still does it. If you take their hearing away, it still does it. If you put a transparent barrier between the rat going back into the cage and the next rat coming out, it still does it. But if you put an opaque barrier and they can't see the rat, then the writhing time is the same. So it has something to do with watching your brothers who you've known for at least a week, and it lowers your pain thresholds. So pain is more than just the individual's pain. It's the family's or social sphere's pain. So now, that's enough on physiology. Yes?
Was that social hypersensitivity a component of opioid-induced hypersensitivity?
Don't know. that would be a good experiment to do. But nobody knew about this social contagion of pain before this experiment was done. So now let's look at pain assessment. How do we assess pain in a patient? We look at the physiologic types of pain because the treatment's going to be different. We try to make sure that we understand, is this acute pain or chronic pain? We identify factors that may be contributing to the pain, because sometimes that's the only thing we can change, is the contributing factors. And here's a group of physiologic types of pain. We could identify 6 of them. You can have nociception, which is an active process of stimulating nerve fibers that sense pain, either by inflammation, certain chemicals exposed to those nerves, or mechanically. The other physiologic type is neuropathic, and you saw some mechanisms of how injured nerves can generate their own pain. Bone pain has its own mechanisms having to do with osteoclasts producing a response in the glial cells. Muscular pain is another one with its own mechanism of action. And then don't forget psychogenic pain. It's just as important as all the others. So how do we treat these? Well, if we have somebody with inflammation, if we're going to think about drugs, we're going to think about anti-inflammatory drugs or treating an infection with an antibiotic. If we have somebody with mechanical causing pain, like a fractured arm that's displaced, we want to stabilize it. And that might take surgery or bracing, or you might just do physiotherapy and get some kind of strengthening, balancing of muscles. Neuropathic pain, we typically use drugs, anticonvulsants, antidepressants. Bone pain, we use drugs that inhibit osteoclasts. NSAIDs we often use for bone pain, for fracture pain. Steroids we do. And then all the osteoclast inhibitors like bisphosphonates and also calcitonin. And then muscular pain, we don't use drugs. At least we probably shouldn't. Because for muscular pain, those don't work very well. And stretching, muscle balance, stabilization, all the physical therapy things, changing your environment so that you're not doing the same activity that perpetuates the muscle problem. And psychogenic pain, we identify and treat anxiety and depression to the extent that we can. We help people with stress management, and we help them regulate their autonomic nervous system, which is often part of the problem. This hypervigilant state actually amplifies pain. A little on opioids. I think we all know that the United States is the biggest opioid user of probably all the countries in the world. We prescribe 99% of the world's hydrocodone and 83% of the world's oxycodone. Yet we're only 4% or so of the world population. And between 1997 and 2002, prescriptions for oxycodone increased by over 200%. Prescriptions for fentanyl by 400%. And then between 97 and 2006, we had an 8-fold increase in oxycodone prescriptions, methadone 9-fold. These are big changes in how we used opioids. And well, I think I want to go back, page down, no, page up. Okay. And of course, we all know that. So here's a map of the amount of prescription painkillers sold by state per 10,000 people as of 2010. Notice Minnesota isn't too bad compared to some of the other ones. Where's the bad belt of high prescribers? Here it is. I had a couple of others. But now, I want you to see the next map, which is how many overdoses, deaths by overdose there were due to opioids. And you can see if they pretty much match. So basically, the amount of deaths is directly associated anyway with the number of prescription painkillers prescribed in the state. And when we...
Is there any other common denominator in the states?
Well, know, that one belt there, you know, that's sort of the Kentucky, Tennessee, North Carolina, West Virginia, that's that, whatever you want to call it, it used to be called, for sort of pejorative, but hillbilly heroin was OxyContin. There was just a lot of prescribing going on. In the Pacific Northwest, maybe the reasons were different, but there was a lot of prescribing going on.
I also noticed that seems to mimic the map of where medical marijuana is legal and is not.
That would be an interesting comparison.
Somewhat.
Some,
The Northwest, certainly.
The Northwest, yeah.
and the middle.
What do we tell patients when we're thinking of prescribing for them? We tell them about the common side effects, constipation, nausea, dizziness, all that. We also should be telling them that it changes your sleep and your breathing during sleep. You can get more pain with opioids. Opioid-induced hyperalgesia, which is hard for them to fathom. 40% of men have a low testosterone being on opioids. And it can cause immune dysfunction as well as depression. Even if there is an initial euphoria, there's often dysphoria with ongoing use, and at least apathy. And there can be some cognitive changes too. And sometimes it only takes one dose of the drug, like intraoperatively, to cause this increase in pain. And there were some studies that looked at intraoperative dose of drug like remifentanil and how much morphine a person used after surgery. And it turns out that those who got the drug opioid intraoperatively used more morphine after. As little as 30 milligrams of morphine equivalent, oral equivalents, can decrease the pain threshold, lead to opioid-induced hyperalgesia. Intraoperative infusions of opioid can decrease pain thresholds or increase pain. And so you have to let patients know when you're going to prescribe. This might actually turn on you at some point and might cause more pain or wider spread pain. This is what I see. As I see the pain is now, they could stub their toe and it becomes like a big deal. Hurts more and it takes longer to recover. Why do some states and some healthcare facilities decide that they're going to limit the opioid dose to less than the equivalent of 100 milligrams of morphine? It turns out the risk of drug-related adverse events when it's used for non-cancer pain increasing with increasing doses above 50 morphine equivalents. And patients on 50 to 99 morphine equivalents per day, there was a 3.7-fold increase in overdose. And those on more than 100 had about a 9-fold increase. And I think this graph is kind of impressive because this is overdose risk compared with the dose of opioid. So if somebody's taking 1 to up to almost 20 milligrams per day of morphine, they don't have an increased risk of overdose. 20 to 50, it's a little more than baseline. But 50 to 100, you got a tripling. And over 100, you have 11 times. This is going up that way. So there's good reason to limit the dose of opioids. And the other good reason is they don't work that well for chronic pain. Here's a Danish population-based study that showed that for patients, or not patients, people with chronic pain had a 4 times higher return to work if they weren't using opioids for chronic pain, and they describe a poorer quality of life if they're using strong opioids for chronic pain. Here's a 10-year epidemiologic study that found that patients on chronic prescription opioids had lower quality of life, increased levels of depression, and more use of the healthcare system. So opioids aren't that great. Even though we know opioids are analgesics. They have the ability to control pain in certain settings, in some ways, acute pain perhaps, but for chronic pain, they don't work that well. And I'm going to skip the assessment of risk stratification. I'm going to skip acute versus chronic pain. Orlando asked me to think about the definition of intractable pain, and I read the state's definition, and you know something? That state definition came from one of my old patients. because he was mad that I told him I didn't think you were a good candidate for using opioids, and he got so angry, but he put his anger, he channeled it in a positive way. He went to a legislator, and he got the intractable pain law passed with Peggy Lepic. So, and in part of that law was a definition for intractable pain. Well, it's sort of a complicated definition. I'm just saying, clinically, I would say pain is intractable when there exist no treatments or strategies that will alleviate it. Now, thinking about that is sometimes people say pain is intractable because insurance won't cover the things that will alleviate it. And sometimes I'm asked to prescribe narcotics when a more expensive non-opioid isn't being covered, which is very frustrating.
Miles, I think the DARE story might be helpful in evaluating those two patients if you want to go back to them.
Yeah, well, I would be happy to because I love the Dyer score, but didn't want to bore people. But this is just one risk stratification scheme, one that I came up with in response to a need up in actually your territory, right? And there are others. There's the opioid risk tool, there's the SOAPP, and most of these are patient-scored, patient questionnaires that are filled out. This one is filled out by the clinician. And basically it looks at the things that we intuitively think about when we're trying to decide, should somebody be on this higher risk therapy? In this case, opioids. And we look at the diagnosis, because we don't want to prescribe opioids for somebody who has a hangnail. If it's uncomfortable, well, do other things. And it's going to get better. We want to know how intractable is the condition. And by intractability, here's my definition. A low level of intractability means there's a lot left to try. Or they're totally disengaged in trying anything else. That's the other side of intractability. The number two would be they've done some things and some appropriate management, but there's still things that should be done before we're all done and all through. And a fully intractable would be somebody who's fully engaged in appropriate pain management, but he's just not doing the job. So that's intractability. We look at various risk factors, including psychological health, chemical health, their reliability, their level of social support and engagement in social roles like student, worker, parent, and the efficacy thus far. Well, one would say it's a low level, so marginal efficacy despite moderate doses. Two would be moderate improvement, or you don't know because they haven't tried the opioids yet. And three would be good improvement, stable doses, improved function. And so if you add all these up, the highest score you can get is a 3 for each one of these 7 categories, 7 factors, and that's 21. The lowest score you can get is a, just seeing if you're awake, okay, 7. And it turns out when we did the statistics on a cadre of 500 patients that we had, this was at the university at Fairview, it turns out that the status, we were going to have a middle ground where they might be a suitable candidate, but not sure. But the statistician said, you know, it's really dividing out into 2 very distinct groups. Not a candidate, 7 to 13. Looks like a candidate, 14 to 21. And I think it's an intuitive tool. I think it mostly works. If all of these things are good, if you get a 21, but they have a positive urine drug screen for methamphetamine or cocaine, well, that trumps this. Okay. So let's look at our pain assessment tools. You all have seen these tools. A lot of people don't really know what the VAS is. They write down in the studies that they do, we did a VAS, when really they mean this numerical 0 to 10 rating scale. And so here's the VAS, except it's not this long, it's only 10 centimeters long. And the patient's supposed to, or the subject, because it's usually used in research, is supposed to say, my pain between worst possible and no pain, here. You just put a line, and then they measure it later. That's not used much clinically. Numerical rating scale is the most commonly used FACES scales for people who don't do numbers, either kids, for example, kids over the age of, I think, 5, or people who just don't get the numbers. The FLAC is the only behavioral observational tool that's used, that's on this list, and that's used in infants and sometimes used in the geriatric population, at least a version of this. Face, what are they doing with their face? What are they doing with their legs? Activity, cry, and consolability. Well, for the geriatrics, you might not have cry and consolability. I don't know, you might. But if their face is all grimaced up, they get a certain number of points. If their legs are all brought up to their chest or shaking, they get a certain number of points. And you can actually score it, and you can translate it into a 0 to 10 scale. So these are some of the scales that are used. But now you know these aren't very good for chronic pain. For one thing, these don't get at that limbic system at all. Well, maybe the face all grimaced up, but other than that, you don't get the limbic system component, which is the key component. So this is only useful in what you might say is acute, self-limited pain, like in the hospital after surgery. So let's look at Vern. And what's his story? And what we're going to do is kind of go through our assessment and see what we come up with for treatment for him. He's 77 years old. He's got Parkinson's and type 2 diabetes, and he's complaining of burning and shooting pain in both feet. What physiologic type of pain exactly? Neuropathic. His joints ache. Well, okay, maybe it's more than neuropathic. And especially his hips and his knees. Pain is bad at night. What is that? What physiologic type of pain is that? It turns out neuropathic is the one that tends to be worse at night. For not just because of the distraction issue, it's more because of chemical diurnal variations in production of certain chemicals. But pain can flare up when he first gets up in the morning, and also if he walks any distance. He was widowed in the last year. He had to move to an assisted living apartment. He's fallen a couple of times, just soft tissue injuries, thankfully, no fracture. He takes ibuprofen and acetaminophen. With codeine he tried, they weren't effective. Hydrocodone with acetaminophen made him confused and too constipated. He's not going to take that. He jokes, might as well put me in the pine box right now, doctor. There's nothing that can be done. If you look at him, his affect is discordant with his depressed mood. His gait is shuffling and wide-based. He's got postural instability. What's that? It's shuffling, wide-based. It's his Parkinson's. He's got joint deformities in the hands and knees consistent with his osteoarthritis. He's got a sensory loss to pin and vibration in both feet and the distal legs. He's got a positive Romberg sign, which means he can't stand feet together, eyes closed, because he's got loss of position sense, probably. His loss of reflexes at the Achilles tendons. Feet are sensitive to light touch. You pull his socks off, it's painful. And by the way, he's got a sacral decubitus ulcer. We look at contributing factors and barriers. Now this isn't him necessarily, but we look for things that are making the pain worse, like depression or anxiety, poor posture, intercurrent illnesses. And I'll give you a great example of a contributing factor. Somebody with post-herpetic neuralgia gets a pneumonia, they're coughing, and the post-herpetic neuralgia, let's say, is a truncal dermatome. Every time they cough, that thing just goes through the roof. Well, the cough is a contributing factor to his post-herpetic neuralgia. And maybe we've done everything we could. Maybe it's normally under decent control. But now with his bronchitis, his pneumonia, and his cough, if we don't control that, it's going to be worse. So sometimes all you can do is control the contributing factors. Barriers are things that are preventing us from giving a good pain treatment or making a good assessment. Insurance, not covering certain things, low motivation on the part of the patient, personality issues. Chemical dependency is a barrier because it colors the assessment. I have so many patients even tell me, they're not going to tell me that my pain, I'm not going to tell you it's less than 8, because I know you're going to take the meds away. Well, okay, we won't ask you that question. So chemical dependency is a barrier. Sometimes cultural barriers prevent us from rendering treatment. And then the last thing we do after we assess physiologic type, contributing factors, barriers, we look at disease burden. How much disease burdening this patient, and that tells us whether we're going to take a more palliative approach to the condition or a more restorative, rehabilitative approach. We'd like to take a rehabilitative approach, get people on their feet, get them functioning. But sometimes when so many diseases mount, whether it's cancer or obstructive lung disease, and they can't even take 2 steps without getting short of breath, well, that's a disease burden that you're not going to be able to overcome. So where do you think Vern is? Remember Parkinson's, diabetes, peripheral neuropathy?
He's Well, depends on his goals, maybe.
Yeah, we should ask him. But,
Yeah.
Well, he wants to be in the pine box. But, if I go my finger here, maybe you guys can just raise your hand where you think he is as far as disease burden, if you remember the case, low to high or even end of life. So here we go. Okay, let's see where the hand's going. Oh, not yet. Okay. Nobody's raising their hand? There we go. Yeah, okay, medium to high, most people, and I would agree with that. And so, yeah, we want to help him with his symptoms, but there's still room for some rehabilitation. And I think it's helpful for us to make that assessment to help guide us into how much are we going to expect of our patient. They're not all going to go to the gym 5 days a week, or they're not all going to, do all the rehab things. They're not all going to go back to work. So, how do we formulate Vern's case? We're going to say he has painful diabetic neuropathy and some muscle dysfunction because of his Parkinson's and his rigidity and bradykinesia. He also has osteoarthritis, which hurts his joints. He's got that decubitus ulcer, which maybe you didn't even know about. He's got some contributing factors. He's grieving his wife. He's grieving the loss of his apartment, maybe even more than his wife. And so he's depressed. And managing that is going to be an important way to reduce that. The barriers, he's already on his anti-Parkinson's drugs, and we maybe can't get his bradykinesia better. Risk of falls is a barrier. He's going to have to use a walker, both because of his Parkinson's, but also because of his neuropathy. And he hasn't tolerated the Vicodin. Made him too constipated and confused. So we got a barrier there. Disease burden fairly high. And it says here take mostly palliative, but I would say you could take a mixed approach. So what's the plan of care for his diabetic peripheral neuropathy? Well, we want to use the drugs and treatments that are for neuropathy. We want to be as specific as we can. For his OA, well, I don't know if you believe in glucosamine, but you could give an NSAID if you could tolerate it. Acupuncture might help OA. There's a few studies that suggest that it does. For muscular pain, we're not going to use drugs for that, but we're going to put him in a pool and let him start moving a little easier. And then for his decubitus, I like that topical morphine. But contributing factors, treat depression, and it might even help his diabetic neuropathy pain too. Some of these drugs do. Put him in the pool therapy because he'll be in with a group of old ladies, and it might help. So ask him if he wants to join a grief group. He might not want to. So, and then the barriers, well, do the best we can to manage his Parkinson's, give him a walker, and then let's maybe, if we can, pick a different analgesic that he might tolerate better. And look, he's feeling better, and his kids are wishing him a happy birthday. So, what does the future hold for pain management? We're starting to realize how much the brain and spinal cord play a role in perpetuating chronic pain. And if it can be plastic in a negative way, let's make it plastic in a positive way. Let's make it work for us instead of against us. Let's deactivate the abnormal glial cell hyperactivity. Let's deconnect the overconnected. Let's break down some of these barriers to interdisciplinary treatment, which we know help people, but insurance companies tend not to want to pay for it because they cost them $20,000 or so. But heck, one surgery can cost $50,000. Preventing pain through preventing pain would be a key thing to do. Education, public health awareness, occupational health, all those things could help. And hey, my timing isn't bad, because we're back to the tale of two patients. London and Paris. So remember London? She was the retail sales lady, same accident. She's just not tolerating her full-time position. She wants to have a better quality of life, and she wants to work for it. Do we want to recommend medical cannabis for that patient? You know, she probably wouldn't take it. That's my guess. Paris. She's same accident. She's working sort of a low-level position. I'm not saying it's not hard work. She's not exercising. She's got some significant chaos in her life and trauma, which contribute to her pain. It amplifies her pain. She's got psychosocial stress. She takes too much opioid, and it's not even doing the job because she's pretty miserable anyway. And she's got a bunch of other pain problems too, and are we addressing these? She wants something stronger for the pain. Well, are we going to recommend medical cannabis for that patient? She would take it. But are we going to add to her alprazolam and her 8 hydrocodone a day? I don't know. I think we want to be sure that it somehow does a much better job than all of these other treatments, and that we're not ignoring her other distress and not just some analgesic score that she's getting. So anyway, that's the only 2 cents I have on that. So I welcome questions.
Thank you so much. Wonderful presentation. Maybe I'll get the feeling of the group. We were going to push through, but it's been sort of a long stretch. Would you like to take just a couple of minutes just to stand and stretch before we sail into questions, or you want to push right on?
Take 5.
So we just cut this up a little bit if it would might freshen us up today, because I think the questions and answers are a very valuable part of